carefully. We want to listen carefully as she makes the presentation. We also have the privilege of asking questions for clarifications or comments after the discussion, after her presentation. We would also have, of course, if you wish, you can also send your questions to the chat group, which she will be able to take later. Dr. Ogumorede, you're welcome, and you have the floor, please.
Thank you very much, sir. Good evening, everyone. Good evening, Masa. Thank you for this opportunity. I'll be presenting sleep disorders and migraine headache. Am I audible, please? Hello?
Yes, we can hear you. Please go on.
Okay. I'll be presenting sleep disorders and migraine headache. Okay. Using this outline, the introduction, pathophysiology, epidemiology, types of sleep disorders and migraine, management, and conclusion. By way of introduction, sleep is a recurrent, reversible, periodic, and cyclic active and physiological process that is essential for life. It's important in the regulation of immune system, in neurodevelopment, memory health, and mental health. And the requirement for sleep varies with age. An average adult is expected to have about 6 to 8 hours of sleep per day, while in the younger ones, it's much higher. So sleep is very important for life itself. And sleep is composed of 4 to 6 recurrent sleep periods, each of them lasting for about 8 to 130 minutes. And there are two main stages. That's the non-REM, that's the non-rapid eye movement, and the REM. The NREM is divided into N1, N2, N3 stages, then followed by the REM stage. This is a picture trying to describe what happens in the sleep cycles through the night. Usually they occur in succession, and we have about 4 to 6 cycles per night. There's an international classification of sleep disorder by the ICSD, and this is the third classification in which sleep disorders are classified into insomnia, and they are subdivided into chronic insomnia disorder, short-term insomnia disorder, sleep-related breathing disorder, which include the central sleep apnea, the obstructive sleep apnea, and there's a central disorder of hypersomnolence, which include the narcolepsy, the idiopathic hypersomnia. The parasomnias are divided into non-REM and REM-related parasomnia. There's also the disorder of circadian rhythm sleep-wake disorder, and there's a sleep-related movement disorder, which include the restless leg syndrome, sleep-related bruxism, and periodic limb movement disorder. Some of these disorders occur in migraine. I'll be introducing migraine, and migraine is a type of primary headache. Other primary headache include the tension type headache, the migraine headache, the trigeminal autonomic cephalgias, and other primary headache. Migraine is one of the most common, is the most common reason why patients come to the hospital with a complaint of headache, and it's described as characterized by lateralized intense, throbbing pulsatile pain on the head, and it's associated with nausea, vomiting, photophobia, and it's usually associated with poor quality of life, leading to considerable disability and several psychiatric conditions like anxiety and depression. And the International Classification of Headache Disorder gave a criteria for making a diagnosis of migraine headache. There are types of migraine headache, can be common migraine or the common migraine, and which is the migraine without aura. That occurs, that accounts for about 80% of migraine, while 20% is the migraine with aura. The common type of migraine is migraine without aura, and it's classified based on the ICHD criteria, in which there must be at least 5 attacks lasting for 4 to 72 hours when untreated or unsuccessfully treated. And it must have at least 2 of the following characteristics: unilateral in location, pulsating quality, moderate or severe pain intensity, aggravated by physical activity. And during the headache, there must be at least 1 of either nausea and or vomiting, photophobia and phonophobia, and it must not be better accounted for by another ICHD3 diagnosis. This is a broad classification of migraine without aura, with aura. Those with aura can either have brainstem aura, hemiplegic migraine. There could be retinal migraine. There is a chronic migraine. It could be status migrainosus. Then commoner in children, they could have abdominal migraine, benign paroxysmal vertigo. The pathophysiology of migraine. Migraine is complex and it is symptomatically heterogeneous brain disorder. The pathophysiology is not well understood, but some theories have been proposed, which I will try to explain this evening. And also, there are individuals that have genetic predisposition. Of note is that migraine is commoner in the young, within 18 to 40 years, and it's commoner in females because of the sudden fluctuation in the hormone in individuals. So it's commoner in females. And there are phases, about 5 cases of migraine headache: the prodrome, the aura in those with aura, and there could be the headache, postdrome, and the interictal phases. That's 5 phases. And the prodrome symptoms include things like fatigue, drowsiness, yawning. These have been associated with the hypothalamus, as some of these symptoms have been shown have shown that the prodromal stage originates from the hypothalamus. Then there's an aura stage in those that have aura that's lasting 5 to 16 minutes, and there's a headache phase itself. Some of the aura include things like the commonest type of aura is visual aura, and they could have flashing light, scotoma. These usually last for about 5 minutes, last 5 to 60 minutes before the headache itself. And the headache itself would be unilateral, troubling in nature, severe, and could be associated with nausea and or vomiting, or photophobia and phonophobia. There's a recovery phase, that's a post-drome phase, in which individuals will be tired, they could have somnolence, they could have difficulty with concentration. Then the interictal phase, which varies with individuals. This is a picture trying to show the structures that have been linked with migraine headache. Of note is the trigeminal cervical complex. We all are aware of the trigeminal nerve, which is cranial nerve 5. That's V1, V2, which is responsible for the sensory innervation to the face, the eyes, the muscles, including the meninges and the vascular system of the brain generally. Then also structures like the thalamus, the hypothalamus, the periaqueductal gray matter, the locus coeruleus. These are structures that have been linked with migraine headache. And it's been said that individuals that are predisposed to migraine have their hypothalamus has lost the inhibition to the limbic system. And migraine has been said to start from a cortical spreading depression as proposed by Liu in 1944. And a cortical spreading depression is like a spread, like a movement with about 2 to 6 millimeter per minute. And its onset is said to have been as a result of imbalance in the ions. There's increase in the sodium chloride ion intracellularly, with an increase in the potassium ion extracellularly. With increase in intracellular sodium ion, this leads to neuronal swelling and leads to bleeding, and this would eventually lead to would lead to death of some of the neurons, leading to hyperemia. That's increase in blood supply, with an eventual oligemia. This eventual oligemia leads to reduction in blood supply to the dura, and with a reduction in blood supply to the dura, there's something it results in a kind of sterile inflammation, activating the trigeminal nerve. With the activation of the trigeminal nerve, some neuropeptides are being released from the end terminals of the trigeminal nerves. Some of these neuropeptides include things like the VIP, that's substance, there's vasoactive inhibitory peptide, substance P, calcitonin gene related peptide. And some of these peptides have been used in the knowledge of this peptide have been used in formulating some of the drugs that are used in the treatment of migraine. So the activation of this vasoactive peptide leads to vasodilatation. It also leads to activation of nociceptive receptors, which lead to pain that is being felt on the head. And because there's an afferent from from the trigeminal nerve, no cervical system, and the locus coeruleus, all of them all are being relayed through the thalamus to the cortex, and this is responsible for some of the symptoms that are seen in migraine, things like emotional and cognitive symptoms. Some of them complain of impaired sleep. Some of them complain of headache, nausea, cognitive due to the involvement of the midbrain. Because of the involvement of the amygdala, there are emotional symptoms, there are problems with pain processing, and also there are some neurotransmitters that have been associated with in pathogenesis of migraine, things like dopamine, things like noradrenaline, things like serotonin, and these have been used in selecting drugs that are useful in the treatment of migraine. The epidemiology of sleep disorders in migraine. It's been said that sleep disruption could serve as a trigger for migraine attack, and pain from migraine can also disrupt sleep, giving it a bidirectional affectation. And restful sleep is being said to relieve migraine attack. And it's been shown that patients with migraine have higher prevalence of poor sleep quality compared to the normal population. And 60% of subjects with migraine were discovered to have sleep disorders. Duman et al. Reported that in about 61.4% of migraine headache, they were found to have sleep disturbances, and there was improvement in the symptoms of migraine and that of sleep with the use of migraine prophylaxis. In a study done in Obafemi Awolowo University, um, 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 in 2023, it was discovered that poor sleep was a second trigger for migraine headache among undergraduates in OAU. So, followed by stress, poor sleep was identified as a trigger for migraine in that population. Also, a study done by Suzuki in Japan trying to find association between the burdens of comorbid sleep, headache-related disability in patients with migraine. He studied about 215 patients, and he found out that there were some sleep disorders in migraine. And top on the list was that of insomnia, 71.6%. 71.6%. Restless leg syndrome was found in about 25.6% of the population. Sleep apnea was found in about 10.2%, and he found out that there was at least one sleep problem in 87% of migrainians. Still, this is a table from the study also. He found out that most of the participants, the migraine patients, have more than one type of comorbid sleep disorders. Some of them had more than one. Some had insomnia with excessive daytime sleepiness. Some had restless leg syndrome with sleep apnea. And he found out that the level of disability was higher depending on the number of a comorbid sleep problem. And this was statistically significant. He found out that the Beck Depression Index was higher with an increase in the number of comorbid sleep problems. So this tells us that in treating her patient with migraine or any type of headache, we should take notes and ask them questions if necessary, give them sleep logs to be able to assess their sleep patterns and diagnose the type of sleep problem they have, and it will help in the treatment and improve their quality of life. Some theories have been proposed to explain the pathogenesis of sleep disorders in migraine, and one of them is that of shared anatomical structures. We find out that in pathogenesis of migraine, the hypothalamus is involved, and that of sleep. The hypothalamus is involved in modulation of sleep, appetite, trigeminal pain system, and the supraoptic nucleus actually plays a very important role in the regulation of sleep arousal. The orexinergic system. Orexin is actually a neurotransmitter and hormone that is released in the lateral hypothalamus, and it's been found to inhibit neurogenic dural vasodilatation. And we should remember that in narcolepsy, especially type 1, that is reduced orexin. So in individuals that have narcolepsy, they are predisposed to having migraine. The same thing for individuals with migraine can also have narcolepsy. Also, the pineal gland is also a shared anatomic structure, and every individual has a pineal gland, and the pineal gland is an epithalamic structure that produces melatonin. based on the stimulation from the suprachiasmatic nucleus. So the production of melatonin occurs more in darkness while light suppresses its activity. And because its production is mainly circadian and it helps to regulate functions like wakefulness, sleep cycle, and it's been said that dysregulation in the cyclic secretion of melatonin can occur in migraine patients. And melatonin has also been used in drug treatment of migraine in patients. This is a diagram trying to depict what I just explained on the shared anatomic structure between sleep in sleep disorders and migraine disorder. Found out that the cortex is also involved in promotion of wakefulness, and it's also involved in pain processing. The thalamus also promotes wakefulness and integration of subcortical sleep input, and is also involved in relay of the nociceptive information from the trigeminal cervical complex. The ventrolateral preoptic nucleus actually helps in stabilization of the waking state, and this structure also helps in pain transmission from afferent fibers from the trigeminal cervical complex to the thalamus. The dopaminergic A11 nucleus in the hypothalamus is known to be responsible for the premonitory migraine symptoms like vomiting, like fatigue, like yawning, and it's also been associated with restless leg syndrome. Another theory to explain the pathophysiology of the relationship between sleep disorders and migraine is that of the psychological theory and the psychological factors. And psychological factors have been found to have a role. And there's a biobehavioral model that has been used to explain the link between chronic insomnia and chronic headache. Individuals that have chronic headache have some maladaptive behavior. Most of them spend excessive time in bed. Some of them use sleeping aids. Some of them ingest stimulants. And this collectively create a vicious cycle and worsen sleep. And it leads to a catastrophic attitude towards health pain. This is a model I was trying to explain. It's been discovered that some individuals that have migraine have some other chronic symptoms like fibromyalgia, other pain symptoms. They could have chronic fatigue syndrome, and because of this, they have some of them have they have this disruption in their sleep physiology, which eventually lowers the headache threshold, and it gives them more propensity for migraine attack. And some of them get involved in use of caffeine, excessive daytime naps. Some of them use medication overuse, and these are some maladaptive behavior that are actually coping strategies for them, and it eventually leads to disruption of sleep physiology, causing a kind of vicious cycle, sleep disturbance in chronic migraine. I'll talk about some questionnaires that have been used in evaluating sleep disorders in migrainians. Commonly are the Pittsburgh Sleep Quality Index, the Insomnia Severity Index, International Restless Leg Syndrome Group Consensus Criteria, usually in restless leg syndrome, then Epworth Sleepiness Scale in individuals with obstructive sleep apnea, and Stop-Bank Scale is also used in obstructive sleep apnea. Objectively, sleep disorders and migraine can be assessed using polysomnograph, which is actually the objective tool in assessing sleep disorders, and it's a diagnostic tool, and it consists of electrooculagram, EEG, EMG, and they help to evaluate all sleep stages. It also consists of a thermosistor, nasal cannula, and abdominal and thoracic belt sensors that are used to detect presence of sleep-related breathing disorders. And some of the parameters that are being measured include latency, sleep latency, which is the first time of sleep stage seen on epoch. This is a picture of results from a type 1 polysomnograph showing the different parameters that are being assessed by the PSG. And the time from the first REM sleep stage is called REM latency. The sleep efficiency is the ratio of the total sleep time to the total recording during an all-night polysomnography. And the PSG can help to diagnose sleep-related breathing disorders, parasomnias, sleep-related movement disorders, and insomnias. Multiple sleep latency test is a type of polysomnography, and it's kind of limited in terms of not all the channels present on the PSG are present on the in when you are assessing the multiple sleep latency test, and is used in the diagnosis of central disorders of hypersomnolence like narcolepsy and idiopathic hypersomnia. And to make a diagnosis of narcolepsy, one needs a mean sleep onset latency of 8 minutes or less and 2 or more sleep onset REM period. It's done with about 5 nap trials at different circadian rhythm, each separated by 2 hours. So one need a minimum of 10 to 11 hours in doing a multiple sleep latency test. The actigraphy is actually used to assess body movements, and Bruni et al. Actually used actigraphy to study sleep and migraine in children and control, and it was able to assess the total sleep duration, the sleep onset, the time in bed, and the sleep efficiency. And it found out that in patients with migraine, they actually have a sleep onset latency that is higher. The time they spend in bed till when they eventually get to sleep is higher than that of controls. That was a study done by Bruni et al. So I'll be talking about some specific sleep disorders associated with migraine, and they include insomnia. Insomnia is the most common sleep disorder in migraine, and it's actually a risk factor for chronification of migraine. It's defined as difficulty with sleep initiation, duration, consolidation, despite having adequate time of sleep, and it results in daytime consequences. Kim et al. Reported a prevalence of 25.9% of insomnia in patients with migraine in comparison with those without migraine. And there's a report that there's an increased risk of developing migraine 11 years after the onset of insomnia and vice versa. They have this bidirectional relationship. And hypothalamic and brainstem dysfunction have been hypothesized as common pathological mechanism in migraine and insomnia. Like I spoke about earlier, that they share anatomical, as in hypothalamus is an anatomical structure that is involved in the pathophysiology of migraine and that of sleep also. So that could explain the bidirectional relationship between migraine and insomnia. And for management of insomnia in migraine patients, it's advised that while taking history for patients with migraine and any other headache disorder, one should ask about their sleep patterns. How many hours do they spend to sleep? What time do they get? Do they feel refreshed when they wake up? Do they feel, yes, that and one can even administer some questionnaires like some of those I mentioned earlier. Then one would need to ask about some of their habits. One might even need to give them a sleep log, and objectively a polysomnography is still the best diagnostic test to evaluate insomnia, but we can still make do with what we have. And in treatment of patients with insomnia in migraine, the cognitive behavioral therapy is a non-pharmacological treatment, and it's composed of stimulus control with sleep restriction. Stimulus control involves advising, talking to patients, and trying to reassociate the bedroom with sleep. We find out that some people do other things in their bedroom. Some people read in bedroom. Some people take calls in bedroom. Some people even watch movies in bedroom. So stimulus controls entail techniques to reassociate the bedroom with sleep, and it means limiting the hour time in bedroom and establishing a consistent sleep-wake schedule. It's very important to have a consistent sleep-wake schedule. I go to bed at this time, I wake up at this time. It's very important in management of insomnia in migraine. Then also it combines sleep restriction, and sleep restriction entails restricting the time in bed to the total sleep time. And this increases with this as sleep efficiency increase. And this helps to increase the total sleep time, and it improves the sleep efficiency. And also, it's been found out that the cognitive behavioral therapy in treatment of insomnia, it produces large effects that's equal to that of pharmacotherapy and even is more durable. And instead of just counseling on sleep hygiene alone, cognitive behavioral therapy in insomnia involve the sleep control and sleep restriction that I mentioned earlier as in management of migraine. And for the pharmacologic management, we all know that there are indications for preventive therapy in migraine, things like presence of more than four and migraine attack in a month, presence of disabling auras when patient is unable to tolerate acute medication for migraine. So there are indications for giving some preventive, and some of the preventive that can be used, especially in patients with insomnia, include amitriptyline and melatonin. They can be considered as prophylaxis. Thereby, one is taking care of the patient's insomnia and also preventing migraine. Another sleep disorder in migraine is parasomnia, and parasomnias are a group of sleep disorders that are characterized by undesirable movements, perception, emotion, dreams, and autonomic nervous system that may occur during sleep, within sleep, and during arousal from sleep. And it's not just disrupt the quality of sleep of the patient, it disrupts that of the bed partner too. And parasomnias are divided into REM parasomnia and non-REM parasomnia. For REM parasomnia, they have this dream enactment, and in fact, at times they kick their partners during sleep. And the serotonergic and orexinergic system, they've been said to play a role in patients with non-REM parasomnia and migraine. A study done by Suzuki et al. Demonstrated dream enacting behavior in 24.2% of patients with migraine. So it tried to compare patients with migraine and their control group, and he found out that patients with migraine have higher incidence of dream enacting behavior. That's 24.2% in comparison to the control group. And the presence of this dream enacting behavior is associated with higher levels of headache disability and poor sleep quality. Another study used polysomnograph to to confirm patient with somnambulism, that's sleepwalking. That's a type of non-REM parasomnia. And it found out that patients that have somnambulism have an increased risk of migraine than any other headache type. Bellini et al. Also reported that there's higher incidence of sleep talking and bruxism in patients with migraine as in children, most especially in comparison with controls. And he found out that sleepwalking was higher in patients with migraine with aura in comparison with those without aura. This the study done by Lopez among patients that sleepwalk. And he found out that generally for patients that sleepwalk, they have an higher incidence of chronic pain, they have an higher incidence of headache and migraine in comparison to controls that do not sleepwalk. And he tried comparing and adjusting the insomnia severity index and the Beck depression inventory. And he found out that it was statistically significant that patients that sleepwalk have higher incidence of headache and migraine. For patients that have parasomnia and migraine, measures to make, because for patients that sleepwalk, some of them will get out of their bed, walk around, in the middle of the night, and most of them don't even remember, so it's advisable to make the bedroom safe to minimize the risk of injury. One can remove obstructions in the bedroom, one can close the window, one can you advise them to sleep on the ground floor instead of sleeping on the second or third floor. And then psychotherapy and relaxation therapy have also been found to help in patients that have parasomnia. Then one could do anticipatory or scheduled awakening so that when you notice that it's almost time, I don't want this patient to sleepwalk at home, you can just wake them up, so as to prevent them from sleepwalking. Another sleep disorder in migraine is restless leg syndrome, which is also known as Willis-Ekbom syndrome. It's a neurological condition that characterized by an irresistible urge to move the leg. They just want to move the leg because they have the urge to do so, and it also has this bi-directional relationship in the sense that some patients with migraine have restless leg syndrome, and patients with restless leg syndrome also have migraine headache, like I listed the percentage in my slide. And presence of restless leg syndrome in migraine has been associated with higher migraine headache severity, photophobia, dizziness, and migraine related disability. And because of the shared dysfunction in the dopaminergic system of the A11 nucleus of the hypothalamus, has been used to explain the link between restless leg syndrome and migraine. It's been known that the prodromal symptoms in migraine, yawning, tiredness, have been linked, and some of the vomiting have been linked to excess dopamine And it's been said that giving antidopaminergic agent at times help in the treatment of migraine. And the symptoms, okay, I've mentioned this: yawning, mood changes, irritability, suggests that there's hypersensibility of migraineurs to dopaminergic agonist. And the dopaminergic hypothesis in the comorbid association of migraine and restless leg syndrome has been supported by the fact that that migraineurs with restless leg syndrome report more premonitory symptoms more than migraineurs without restless leg syndrome. So consideration for treatment in restless leg syndrome in migraine, it's advised to check for always take history, ask questions. Does the patient have urge to move the leg? And ask for the features of restless leg syndrome in migraineurs. And it's better to adopt a specific treatment because presence of restless leg syndrome worsens the disability and the quality of life in migraineurs. And we should remember also that drugs like tricyclics, amitriptyline, selective serotonin reuptake inhibitors can also cause restless leg syndrome. So, and these are some of the drugs that can be used as preventives in the treatment of migraine. So it's good to consider some of these drugs to be sure that it's not the preventive drug that you are using in treating migraine that is causing the restless leg syndrome. So one should take adequate history in taking care of these patients. Another sleep disorder in migraineurs is that of obstructive sleep apnea, which is characterized by repeated episodes of airflow reduction that can lead to partial or complete obstruction of the upper airways during sleep. And generally, with obstructive sleep apnea, because most of them tend to mouth breathe, they wake up with awakening headache. And this is in a study done by Law et al. Reported that this accounts for in patient obstructive sleep apnea, about 29% of the population have awakening headache, and just 15% of them had tension type headache. And migraine is less frequent in patients with obstructive sleep apnea. In fact, it concluded that the frequency of obstructive sleep apnea and migraine is comparable to the general population. And he explained the pathophysiology is being explained by because of the intermittent hypoxia in obstructive sleep apnea syndrome, it's been said to lead to activation of inflammatory pathways. And some of these inflammatory pathways, I mentioned earlier that there's steroid neurogenic inflammation in the pathophysiology of migraine. And it's been found that adequate treatment of obstructive sleep apnea in migraine patients with CPAP led to a reduction. So we should know the tools that are used in assessing obstructive sleep apnea. When we look at our patients, you can measure their weight, the neck circumference in males and females. You can check the Mallampati score, ask them if they snore at night. You can use the Epworth sleepiness score also to assess, and treatment could include weight reduction, adenotonsillectomy, especially in pediatric age group, and majorly CPAP has led to reduction in migraine frequency in them. This same study reported that for some migraine patients that had obstructive sleep apnea, with the use of CPAP, that's continuous positive airway pressure therapy, within a year of treatment led to reduced frequency of attack per month. Um, Yes, this is sorry. Okay, so this is the initial a year, that was before the use of CPAP. That's the light blue, and the deep blue is with the use of CPAP. So it led to reduction in frequency of attack per month, and the duration of attack in hours was also reduced. The intensity of migraine attack using the visual analog score and the inability to walk was reduced with the use of a year use of continuous positive airway pressure. Then you need to use acute medication was also reduced. So taking care of comorbid sleep disorders in migraine patients can actually help improve their quality of life and reduce the headache frequency. Another headache sleep disorder in migraine is that of narcolepsy, and narcolepsy type 1 specifically is characterized by a tetrad of excessive daytime sleepiness, cataplexy, hypnagogic hallucination, and sleep paralysis. And Suzuki reported that patients with narcolepsy exhibit greater headache frequency compared with their with healthy control. So generally, an individual that has it also has this bi-directional relationship also, because they share this orexinergic pathway, like I mentioned earlier. So individuals with narcolepsy and idiopathic hypersomnia have greater headache prevalence, and also the prevalence of migraine in narcolepsy was reported to be about 23.5, and idiopathic hypersomnia was about 41.2. I mentioned earlier that this orexinergic system plays an important role, and because orexins have also been noted to modulate the trigeminal system, an increased prevalence of migraine is found in patients with narcolepsy. This is a study done. Okay, this is a result of the study. It found out that, okay, so this is the for narcolepsy. Okay, so for patients with narcolepsy, generally they have high incidence of migraine, more than tension type headache. And the same thing goes for idiopathic hypersomnia patient in comparison with controls. Most of the controls have more of tension type headache than migraine headache. Further buttressing the points that the orexinergic pathway is actually, because it's shared in the pathophysiology of narcolepsy and migraine, patients with narcolepsy are predisposed to migraine, and vice versa. And it's been found out that for such patients, there's a significant relationship in the airport sleepiness scale also, because they don't get to sleep well and during at night, and they sleep more during the day. Then also they have more sleep disturbances, and they also have more, they are predisposed to use of psychostimulants, like the biobehavioral model I spoke about earlier, leading to a vicious cycle, and some of them have to use antidepressants. um an experimental study that was done found out that dual antagonists of both orexin 1 receptor and 2 actually reduced dural vasodilatation, and it's being proposed that some of those drugs can be used in the treatment of both narcolepsy and migraine. And generally, treatment for narcolepsy include modafinil, sodium oxybate, selective serotonin reuptake inhibitor. And one should note that antidepressants and some anti-seizure medications that are used in the treatment as preventive therapy in migraine can lead to excessive sleepiness. So it's advised to rather give tricyclic antidepressants, which will help them sleep better at night, than giving some of these anti-seizure medication. Also, beta blocker, which propranolol and other ones that are used as preventive in migraine, have been associated with nightmares, and it can lead to frequent awakening during sleep. So one should also consider that in medication, especially when one is thinking of parasomnias. It's been advised to use drugs like calcitonin related peptide monoclonal antibodies, other form of treatment like neuromodulation, botulinum toxin, high dose vitamins and supplements can be considered for treatment. Generally, in management of sleep disorders in migraine, adequate history taking is very important. One needs to take adequate history, time of sleep, what happens during sleep, quality of sleep, does the person feel refreshed on waking up. Then one would need to examine too, check the Mallampati score in obstructive sleep apnea, measure the weight, measure the neck circumference, and also the use of sleep diary and sleep log, very important. And one needs to, as part of a history taking, you all know that use of caffeine will prevent sleep. Caffeine can also trigger migraine. So one really needs to take adequate history. In some cases, one may need to do a polysomnography, in which is the objective measure in evaluating sleep disorders generally. And one, it's important to identify the triggers, confirm the diagnosis, and one should help patients in behavioral therapy and to evaluate outcomes. Non-pharmacologic treatment generally for migraine, which would also help them to sleep, include advising them, because most of them are photophobic, Encourage them to sleep in a dark, quiet room. They should avoid use of caffeine, nicotine, and avoid use of electronics before bed. Once you want to sleep, drop your phone, because even the light in the phone can inhibit production of melatonin, thereby worsening insomnia in patients. And cognitive behavioral insomnia treatment I mentioned earlier, using stimulus control and sleep restriction, is important, and one should treat them adequately, give prevent acute treatment and preventive treatment when necessary. Then other forms of treatment in migraine, though not readily available in this environment, that one would consider include use of botulinum toxins, hospital nerve stimulation, non-invasive vagus nerve stimulation can also be used, and it helps to improve the quality of life in patients. In conclusion, migraine is the most common primary headache disorder seen in emergency departments, and that's one of the reasons. Hello? Hello? Okay. It's one of the most common primary
Continue,
headache
please.
disorder. Okay. One of the most common primary headache disorders seen in emergency departments, and it has a complex and it's symptomatically heterogeneous brain disorder, and it's associated with poor quality of life and disability. Presence of comorbid sleep disorders can coexist with migraine and worsen its disability. So it's important to evaluate migraine patients for sleep disorders using sleep diaries, using sleep logs, um, examining them properly for features suggestive of obstructive sleep apnea. Then actigraphy and polysomnography are essential in the identification of sleep disorders in migraine. And pharmacologic management should be carefully considered. Like I said earlier, use of tricyclics, use of SSRI can worsen restless leg syndrome. So one should carefully consider pharmacologic management when treating sleep disorders in migraine. Thank you very much. These are my references. Thank you.
Thank you very much, Dr. Okumodede. That was a very lucid and detailed presentation on sleep disorders in migraine headache. So we have some time. So we want comments, questions, so that we can discuss this in the time we have.
There's a question in the chat box.
Yes, I'm looking at it now. Okay, this is from Chinozo, or Chinonye, sorry. Thank you for the presentation. Sorry I came late. In migraine sleep-related disorders, which one triggers the other? Okay, that's the question. In migraine sleep-related disorders, which one triggers the other? Can you comment on that, Dr. Okumodede?
Okay, thank you very much. Usually, insomnia, poor sleep generally is a trigger for migraine, but eventually it creates this vicious cycle that with poor sleep, migraine is triggered. Patient engages in some maladaptive behavior, use of overuse of medication, of sleeping pills and all that, and it eventually worsens the sleep and it continues to trigger migraine headache. Thank you.
Thank you very much. Comments? More comments or questions? Yeah. Thank you very much, Dr. Modede. Let me maybe ask a question and then maybe one or two comments. Tension headache and migraine, is there a way we can separate the two clinically, or if we have to do some specific tests to be able to identify which is which? Can you comment on that? Tension headache, migrainous headache.
Okay, thank you very much, sir. So there's this international classification of headache disorder criteria in making diagnosis of tension headache and migraine headache. So usually tension headache is usually bilateral. It's this kind of banding headache around the head, unlike migraine, which is unilateral. Then another thing about tension headache is that tension headache is not usually as then the duration of tension headache lasts at most for 3 hours, doesn't last up to 72 hours that happens in migraine. Then tension headache is mild to moderate in severity, unlike migraine headache that is moderate to severe. Like I said earlier, migraine headache is unilateral, while tension headache is bilateral. Then another thing about tension headache is tension headache is not usually associated with nausea and vomiting, unlike migraine headache where patient can have nausea and or vomiting. Tension headache can have photophobia, phonophobia. Also, migraine can have the same. So in terms of the severity, in terms of the location and the associated symptoms, then usually tension headache is relieved with sleep. Most migraine patients have to take medications before they get relieved of their migraine headache. Thank you, sir. And
Thank you very much.
most people have tension headache. Everyone have tension headache at one point in time. Once you get to sleep, it relieves it. But migraine headache are usually triggered. One needs to identify the trigger: meals, stress, poor sleep, menstruation, ovulation, and those other symptoms. Thank you, sir.
Thank you very much. Yeah, thank you very much for that. More comments or questions? Sorry, I'm just looking into the chat. Okay, somebody's hand is up. I can't see that person. Okay. Oh, I thought I saw somebody's hand up. You can also use the raise hand feature so that you can make your comment or ask further questions. I'm checking the chat box, okay. Right, there's a question from Dr. Yusuf. He says, what is your experience with the underlying, what is your experience with, I can't get that, underlying migraine or overlying migraine, sorry, with something overlying migraine. Can you, Dr. Yusuf, you can raise your hand so that you can explain further. Not
okay.
Yeah.
So good evening, sir. Good evening, sir. Good evening, everyone. Thank you very much, Dr. Gumodade, for that beautiful presentation and insights. I just want to see your opinion about what is your experience with patients who have tension type headache now being overlaid with migraine. We all know that sometimes for some few patients, the two can coexist. So I just want to hear your own opinion. What is your experience with patients with tension type headache now coexisting with migraine? Thank you very much.
Okay, thank you, Chief. So for either for some of them have been having this type of there are some, okay, from my experience, I found out that for some patients that have migraine headache, for some of them that have always been migraine patients, at times they have other types of headache, which would include tension headache, and they describe it perfectly. They tell you that, okay, this particular headache I'm having is different from the one I used to have. It's different from the one I used to have. The one I used to have before is one-sided. I know how it feels. But this particular one is usually different. So at times it could even give us an indication that, okay, this is a new a different type of headache entirely. And as part of the red flags in managing headache, one will take note of that, and one may need to ask them to do a brain MRI. But for tension type of headache, yes, it's very possible an individual with migraine can also have tension headache. And usually with the use of paracetamol or NSAIDs, and even some of the drug that is used in treating migraine can also help in tension type headache. And there are some that have been having tension type headache ab initio occasionally and now presenting with a particular type of headache that when they describe it, it's in keeping with migraine. So at times the phenotype switches, and one would just need to treat them appropriately. That has been my experience. I don't know if you are willing to share yours. Thank you.
Okay, thank you so much. Thank you so much. Okay, thank you.
There's another question in the chat.
1 minute, please. Yes, Dr. Tajuddin Abiola, yes, says thanks for this great presentation. Kindly clarify more on the psychological interventions for migrainous headache with comorbid sleep challenges. Can you comment on that? Psychological interventions for migrainous headache with comorbid sleep challenges. Please go on, Dr. Umoredi.
Okay, thank you. Thank you for that question. So, as part of psychological intervention, I mentioned cognitive behavioral therapy for insomnia. And in cognitive behavioral therapy for insomnia, it involves sleep control, stimulus control, and sleep restriction. So for the stimulus control, one wants to restrict sleep, as in the use of the bedroom to just sleep. That means the patient with insomnia and other sleep problem will not go to his or her bedroom except he wants to sleep. Will not read on the bed, will not press phone on the bed, will not watch TVs on the bed. So with that, the brain gets adapt to the use that my bedroom is just for sleep. That is as regards the stimulus control. And the sleep restriction entails having a schedule, like, okay, this is the number of times you're going to spend in your bed, and then you wake up. And this is usually done alongside with sleep hygiene, counseling the patient on sleep hygiene. And that means patient has to avoid the use of caffeine. Patient has to drop his phone before going to bed. The patient needs to avoid the use of drugs and other stimulants that would prevent sleep. So those are measures, non-pharmacologic measures that can help improve a patient with sleep disorder. Thank you.
Thank you. Another question here. In your experience, does effective preventative therapy in migraine significantly alleviate sleep disorders in those who have them? That is the preventive measures. Yes, please go on.
Thank you for that question. So I would share an experience with a patient who the patient has a migraine. 23-year-old female has a migraine, and the features the patient has up to like 15 days of migraine in keeping with chronic migraine, and she qualified for the use of preventive treatment. So I recommended amitriptyline. While amitriptyline is very good for patients with insomnia, comorbid insomnia and migraine, but most people tend to, especially students, want to avoid its use because it makes them sleep excessively. But with low dose amitriptyline, about 12.5 milligrams at night, and this patient took it for up to like 4-5 months, and she completely, in fact, the language she used was that she said her head is free. She feels lighter and her head is free. So she was able to, she didn't have to use acute drugs, sumatriptan, Cafigot, or NSAIDs in her treatment of migraine. In her words, she said her head is free. So which actually shows that amitriptyline was able to help her sleep well, and it also helped her to prevent frequent migraine headaches. So it's been very good as long as the patient can comply. Because that has always been a challenge, especially with students. They tell you that they can't use the drug, it makes them sleep. They want to wake up to read. So compliance has always been the issue. But once they comply, they do very well with amitriptyline. Thank you.
All right, thank you. And another question from Feisha Yoalabi, same person. Sorry, I don't know if you can you speak to any difference in prevalence in sleep disorders in migraine with aura versus migraine without aura. That is the prevalence of sleep disorders in migraine with aura versus migraine without aura. Any comments on that?
Thank you for that question. Actually, the results were not consistent, like some studies, especially for, I think I mentioned parasomnias. That's I mentioned parasomnias that for patients with parasomnia, sleepwalking was higher in those that have migraine with aura compared with those without aura. So there were some studies that showed that insomnia was higher in patients with migraine with aura, and so the results were not consistent. So I think it's advisable we do our own as in administer questionnaires to take our own data to really help us to identify which one is commoner in those with aura and those without aura.
Right.
Thank you.
Yeah, one more question. Can you comment on the use of triptans for recalcitrant migraine with sleep disturbance? What other measures are available? That's from Dr. Abiola.
Okay, thank you for that question. So triptans are drugs that are used in acute prevention of acute treatment of migraine. So sumatriptan not readily available, but generally people use triptans when they have acute migraine attack. So once they take the triptans, they feel they feel better. But for patients with comorbid sleep disorders, like insomnia, one would need to, and with the frequency of the migraine attack, one may consider triptans will not help their sleep, depending on the type of sleep disorders they have. So for patients with insomnia, and those that one can recommend cognitive behavioral therapy. And when if they meet the criteria for giving preventives, one would consider things like amitriptyline, selective serotonin inhibitors. Those would help their sleep more than just triptans alone. Triptans are good for the acute treatment. Thank you.
Thank you very much. Okay, thank you very much. Another question from Deborah Ajayi. Does riboflavin have a role in the prevention of migraine headaches?
Okay, thank you for that question. I actually, it's riboflavin, high dose riboflavin has been listed as part of the treatment, acute treatment of migraine, and the level of evidence, I think it was just about C or B. I've not had any experience with that, but it's been listed as part of the vitamins, riboflavin, some other about like pitacides and some other drugs, non-pharmacologic non-drug treatment for migraine. Riboflavin has been listed, and the level of evidence is, I think, about C or B. I can't remember now, but I don't have any experience with that. But it's been documented that it actually helps in the treatment of migraine. Thank you.
Right. Thank you very much. I think that does it for questions in the chat. Thank you very much, everyone. At some point, we were 48 on the call, and that's quite good. We appreciate your presence. Dr. Ogumodede, thank you very much for sharing your knowledge and your thoughts with us on
Thank you, sir.
Sleep disorders in migraine headache. We truly appreciate that.
Thank you, sir.
Just to add that, as you mentioned, the relationship between sleep disorders, between migraine, anxiety, migraine, depression is bidirectional. And so when amitriptyline helps, one can also, of course, consider the fact that maybe that, because amitriptyline is also a very good anxiolytic at very low dose, amitriptyline, it helps with anxiety. So that may also help individuals who are on the verge of developing migraine as a result of anxiety. So it's a good combination to try and do that. All right. I think
Sure,
that
just
should be it.
another question came in just now.
Okay. In the chat box. Okay, please, what is your experience? Oh, thank you. What is your experience in the use of erenumab in management of recalcitrant migraine?
Thank you very much. So erenumab is a calcitonin gene-related peptide antibody, and it's perfect for chronic migraine. It's given subcutaneously monthly, and it's been said that it helps in reducing frequency, intensity of migraine in those that have used it. Are quite expensive. We only have a number of the I have a number of a rep that distributes it, but I've never had to prescribe it to a patient. I mean, majorly because of the cost. And most times when I give my patient the preventive propranolol and amitriptyline, they do well on that. I've not had cause to prescribe it, but it's a very good drug as a preventive measure for migraine. Thank you.
Right. There is a comment here from Dr. Yusuf, who said his personal experience with erenumab has not been fantastic. Well, that's a comment from Dr. Yusuf. Thank you very much, Dr. Abiola. Thank you very much, Dr. Gumodede, for your comments and response to the various questions.
Thank you very much, sir.
All right. Thank you, everyone. Yeah. Chairman, Professor Komolafe, any comments?
Yes, just to thank everyone for joining, and I want to thank the presenter, Dr. Gumodede, for this excellent presentation. I think many of these questions might be areas for further research. Before we started, there was another webinar on migraine. So I think we can know these questions and see whether we can also study some of these things that have been mentioned further. So while we started, I think Dr. Boadi joined us. I don't know if he's still with us. So I want to appreciate everyone who joined. Thank you. And we wish us a restful night. We all see you at the next webinar next month. Thank you for joining.
Thank you, ma.
Good night.
Thank you. I stay to the end.
Thank you. Good night.
Thank you, ma'am.
Thank you.
Dr. Adi, thank you very much. It's nice to hear your voice. Welcome back.
Thank you.
Bye.
Night. Thank you.